Hello, everyone. Welcome to the first MDisability Provider Webinars in the 2023 series. Today, we're going to welcome Dr. Cheryl LaMore, and she's going to present Home Visits for People with Disabilities, a Family Docs Approach. When she joins us, Dr. Michael McKee will do the introduction.
Thank you so much, Dawn. So Dr. LaMore will be joining us momentarily. But I do want to go ahead, just give a brief introduction. So this is our first provider series webinar for the calendar year for 2023. The title of today's presentation is Home Visits for People with Disabilities, a Family Docs Approach. So we're delighted to have Dr. Cheryl LaMore join us. She's an assistant professor here at the Department of Family Medicine at University of Michigan. Dr. LaMore is going to share some of her experiences providing home visits and also explain how this care has added to her love of practicing family medicine. Dr. LaMore has spent her career caring for patients in multiple levels of care, including serving as an attending physician at the Chelsea Family Medicine as an inpatient service. She also provides care for patients at a local nursing home and performs home visits for her patients who meet this criteria. Dr. LaMore has also included medical students and family medicine physicians to join her on home visit rounds. So as part of this provider webinar series, what we're hoping to do is provide a forum so that people, especially primary care attending, students, learners, so we can learn tips, strategies, and approaches to be able to help improve the care for people with disabilities. So we're gonna give a minute. Dr. LaMore is actually just wrapping up patients, so she'll be on momentarily. So we're just gonna give a second for her to get on board. Thank you, and it's great to see everybody. One other thing we will put in the chat, there has been several provider seminars and webinars that have already been completed. There's various topics that have already been recorded. So if you are interested, we will put in the chat so you can actually go to the website and be able to check out some of our prior ones. If any of you are also interested in contributing to this provider seminar series, let us know. Reach out to myself or Dawn. Thank you so much. Welcome, Dr. LaMore. So what we can do is make sure that you can get your slide deck shared. If you have any issues, we do have your backup file as well.
It is, I know it's in my file. I'm trying to find, let me get it up. Should be, I'm so sorry. I knew that this was going to happen. But I've got my OneDrive here. It should be the first file. There it is. It is loading. Come on, computer.
While you're getting that set, want to let everybody know a few things. So we have a captionist on board. So anybody who may need captioning, they can actually check that out. If you go to the bottom of the screen, it'll say show captions. You can select that. And then the second thing, we welcome any questions. I'm sure there'll be many questions for Dr. LaMore. If you can put it in the question and answer, and we will address them during any breaks in the slides or at the very end.
All right, can you guys see?
We can see it. You may better get into, yep, okay. I think it's
all look good?
Yeah, we're all set.
Okay, I'm gonna shrink this down.
Sure.
So I can see things. It's always curious to move things out of the way so I can see them better. Okay, that's better.
And Dr. LaMore, we just wanted to let you know, we gave an introduction of yourself.
Okay.
So everyone is aware of who you are.
Okay.
And so you can take it from here if you like.
All right, great. Thanks, Mike. So hello, everybody. Sorry, I'm running a little bit late. I just finished up with my patient of the morning. So I appreciate your understanding, but we can launch into my talk. As you know, I'm here in the department. I've been here since I trained in residency back in 2004. Can't believe that much time's gone by. I work with Mike here in Dexter, and home visits have always been something that I like to do for my patients, and I'm going to tell you how I do them in my talk. So my title is called Home Visits for People with Disabilities, a Family Doc's Approach. And why is it not letting me go down? There we go. So I listed some goals and objectives for you here, and I hope that you leave today feeling more comfortable knowing what a home visit is, the kind of patients that would be appropriate for. I'll help you learn how to conduct a home visit for a homebound patient. I'll kind of talk about how I fit it into my busy clinic schedule and how you may be able to even fit it into yours. And then also, if you are an academic provider, you probably have some learners with you at times. And I do, as part of doing home visits, I do take medical students and family medicine residents with me to these visits a couple times a month. So that makes it even that much more enjoyable. So a little bit about the history of home visit use in the United States. Years and years ago, we're talking last century, years ago, home visits were actually an integral part of what it meant to be a family doctor. And in 1930, it was about 40% of all patient-physician encounters in the US actually occurred in a patient's home. But then, jump forward 50 years, by 1980, that number basically dropped to less than 1%. And then, interestingly, in a survey that was done in 1994, American doctors in 3 primary care specialties, and that's internal medicine, OBGYN, and family medicine, about 63% of family physicians actually still made house calls. So it had kind of dropped back, but it was kind of starting to pick up again in the 90s. And a 2016 analysis of Medicare claims showed that between 2006 and 2011, only overall about 5% of American doctors were actually doing house calls on Medicare recipients. And interestingly, the number of those home visits was increasing even then. So home visits in general, there's really been a resurgence of interest because home healthcare, it has so many uses. And so it's increasing partly because there are increasing numbers of homebound patients in America, and the numbers of homebound versus those who live in nursing homes, the number far exceeds those who live in nursing homes. And there is a growing body of evidence that home visits improve patient outcomes. So another good reason to consider offering home visits for your patients if you can make that work for them, because there's evidence that it actually improves outcomes. And many family physicians whose lives kind of are centered around a very busy office or hospital practice have really found satisfaction in seeing their patients in their own homes. And I second that by far. It is one of my favorite things that I look forward to every week. And honestly, the COVID-19 pandemic has presented some unique challenges, but also opportunities for home visits, which I'll get into later. So who qualifies for home visits? So basically, you have to be homebound. And what does that mean? So those who have trouble leaving their home without help. I mean, that's a very simple definition. They can't get here on their own, then that person would be considered homebound. So let's say they use a cane, a wheelchair, some sort of a device for transportation. If they need special transportation to get to and fro, or they need the help of any other person, those patients are considered homebound and would qualify for home visits. And it can be because of a chronic illness, a debilitating diagnosis, or even an acute injury that makes it difficult to leave their home. Also, other homebound individuals, maybe there's a recommendation to not leave their home because of their medical condition. Maybe it causes instability in their condition, and it's safer for them to stay home. And obviously, homebound individuals would be, anybody who normally is unable to leave their home. That's what I want to kind of drive home here, because it's a major effort for them to leave their home. So these are just some examples of patients who would qualify for home visits. So I just pulled some pictures out to provide some visual examples. So obviously, the man sitting in his wheelchair with cerebral palsy, obviously mobility issue there and dependent on others. An elderly woman who requires help with feeding and daily life care. She would definitely qualify for a home visit. And even a child with an extensive disability that makes it difficult for their parents to be able to get them to the office. That patient would certainly qualify for a home visit. And there are multiple other examples, and I certainly would welcome for you guys to maybe share on the chat, which I will review after our talk, about what example comes to your mind as a patient in your practice that you feel, well, gee, that person missed their last visit because there were logistical issues in getting them to the clinic. Well, then reviewing what those logistical issues are, and if it's more than just irresponsibility, and there are other driving factors, then they likely would qualify for home visits as well. So this is just some of the list of covered home health services under Medicare. And so these are adjunctive things that you as a healthcare provider could recommend your patient take advantage of. And other insurance providers certainly follow the lead of Medicare. Medicare kind of drives what insurance companies cover and don't cover. So most other insurance companies will cover similar services. So medically necessary part-time or intermittent skilled nursing care, physical and occupational therapy, speech and language pathology services, medical social services. If there's need for a part-time or intermittent home health aid, if that care is needed. But the unfortunate side of that is that if skilled nursing care is not part of it, then Medicare does not cover just home health aids. So that would be an out-of-pocket expense, not covered by insurance if there was not more than the need of just a simple person to come in and help with bathing, etc. That's something that would have to be covered, unfortunately, by other means, because insurance does not, unfortunately, cover that particular service. And I found this interesting, that injectable osteoporosis drugs, we could bring those out to the house to give the patient versus them having to go out to get that medication. Other durable medical equipment can be delivered right to the home, obviously, and also medical supplies. So this is just a slide that I found from the CDC, that disability impacts all of us. And as you can tell by the pictures here, there are many different types of disabilities, and we have to recognize that in our communities, in our patients, everywhere we go. If we're more attuned to it, we can recognize that patients have certain disabilities, and we want to try to improve their access. So the other, I think, very telling slide here is that 1 in 4 adults has some sort of disability. And I think that's very striking. That's, a quarter of us. And then this slide kind of goes into more definitively the types of disabilities and what percentage of the population suffers these things. So over 11% of us, unfortunately, have some sort of serious difficulty with walking or climbing stairs. Almost 11% of us have some sort of serious difficulty with concentration or remembering or just making decisions about our own needs. About 6.5% of us have difficulty doing errands and living independently. Almost 6% of us have deafness or some sort of serious difficulty hearing. And almost 5% of us have visual impairment. And then more seriously, just self-care, about 3% of us have difficulty even dressing and bathing. So this just tells us, like, overall in the population, it doesn't seem like a huge percentage, but when you add these all up, it gets to that 1 in 4 people have some sort of disability. So this I found very telling too. Disability and health, they're intricately linked. And it is known that people with disabilities have a higher rates of comorbid conditions, such as obesity. More people with disabilities smoke than those without. More people with disabilities have heart disease than those without. And more people have diabetes as well. And you can think of that more as a function of aging, because obviously disability comes on with age. And a lot of these comorbid conditions have onsets later in life, but that's not always the case. And when it comes to accessing healthcare, there are definitely a lot of barriers. So 1 in 4 people with disabilities do not have a usual healthcare provider. And that just made it very sad for me. 1 in 5 have unmet healthcare needs because of cost, and 1 in 4 don't get routine checkups. So that's another, significant portion of the population. So a quarter of people have disability, and then a quarter of those do not get the adequate healthcare that they deserve. So how can we help as healthcare providers? Well, we can try making a difference, obvious in the realm of improving access to healthcare. And doing home visits is just one facet of that. And so the CDC is asking us as partners in providing healthcare to these individuals to consider ways that we can improve healthcare access. And so, helping to build inclusive health programs, promoting healthy lifestyles, monitoring the public health data domain, and seeing where things can be improved, where there is most need, and then obviously performing research to try to reduce healthcare disparities. So now I'm going to transition into how to conduct a home visit. And this is how I do it. And I'm not by any means saying that this is how it has to be done. And you may find other nuanced ways to do it yourself, but this is my experience. So these are what I describe as my home visit necessities. So I reserve a half a day a week. And I wish I had more, but I am not able to do more than that. But I take a half day a week out of my schedule. I do it on Tuesday afternoons, where I have help in scheduling my patients who are homebound. Usually do anywhere from maybe from 2 up to at most 6 visits in a half day. And I typically like to reserve 1 hour for each patient, because it gives you enough time to really observe that patient in their home environment. And in order to build your home visit population, I ask you to talk to your clinical colleagues to help build that patient cohort, because most certainly they're going to say, oh yeah, Margaret didn't come in to see me last week because she's at home right now having had a vertebral compression fracture, so she's not able to be very mobile right now. And so I've built my cohort by talking to my colleagues here at Dexter and asking them to refer to me any patient that they have on their panel that they feel would do very well with home visits. So I've built my practice over time that way. And of course, I pack a doctor's bag. How could you not? With the essential things. And obviously, we can go on listing other things that may be appropriate to carry with you. But the essential things that I feel are necessary are obviously hand sanitizer, if you don't have easy access to their sink to wash your hands, bringing alcohol wipes to wipe things down, wearing masks, and then this near post-COVID era, as providers, we are still wearing our masks in front of patients, and I still wear masks in patients' homes. Obviously bringing your stethoscope, a validated sphygmomanometer, or even an electric blood pressure monitor that you've validated and is accurate. I bought a pulse oximeter off of Amazon for about 20 bucks. And it's lasted now for well over 5 years, so it's pretty decent. I just had to replace the battery once. I have my old otoscope ophthalmoscope combo that I bought back in medical school, and the clinic provides me my otoscope covers, so I take that with me. I don't always use it for every visit, but certainly it's something I'm glad I have. Sometimes you may want to bring an irrigation kit to remove cerumen from the canals, and obviously, bring your peroxide with you. Sometimes if you've got diabetic, you want to bring a monofilament with you, maybe nail trimming accessories. I know Mike had mentioned like a slide board if you have somebody who you want to maneuver with the help of the other care providers in the home to do adequate visits. There are different things that we could go on to add to this, but these are what I carry with me most of the time. So this is how I suggest a time structure to your visit when you go into a person's home for the first time. And certainly these definitely take a full 60 minutes to accomplish. I'm just going to close the door so it's quieter. Sorry about that. Obviously you want to make sure that the caregivers are present for the visit. So you want to make sure that that's arranged ahead of time, that they can be present when you go to the home. And obviously, when you walk into a new home's environment, you want to assess it for safety. And this is not just for the patient's safety, but this is actually for your safety as well. And so I always try to assess whether there's a safe egress for the disabled patient to make sure that, in case of a fire or other emergency, that they're able to safely exit the home. You want to maybe check for working smoke detectors. And then maybe look around the living environment. And I'm not saying you have to go into every crevice of the home, but assess for safety and looking for infestations of insects, mice. Maybe you see some mice turds in the corner. If there's some unsanitary conditions, maybe smell for smoke exposure in the house. All those things are important to document and work toward improving if you do find unsafe circumstances. And of course, you want to gather a history from the patient as well as their caregivers, and you try to do that together. So trying to make the data gathering as a mutual thing so that you're hearing the stories from both the caregivers and from the patient, because it's important to recognize caregiver burden issues when you are first assessing a new patient at a home visit. And obviously obtaining your vital signs, as many as you're able to do. If they are able to get onto a home personal scale, that'd be great to get their weight right there and then versus just recall. But obviously, depending on the disability, that might not be advisable or safe. And then obviously performing your physical exam, trying to do a head to toe as much as possible. You want to do an assessment of their skin integrity, including private areas as appropriate, and obviously asking a family member and or caregiver to be present as your chaperone. And of course, reviewing medications and supplements and actually looking at their bottles to make sure that they're not expired medications, and assessing for polypharmacy. Those are things that I often have my learners do. So, while I might be assessing certain things, then the student and or resident is kind of writing down the names of the medications and the supplements, and then we take time later to assure that the medical record reflects the things that they're actually taking. And then, of course, another important aspect is to talk about advanced care directives and documenting code status. I think that that's a very important conversation to have, even at your first visit. And then in certain jurisdictions, it's important for emergency medical services to know if a patient is a do not resuscitate, then you want to have a written order taped to the back of their front door so that inappropriate services are not given at the time of calling EMS. And then some further considerations. You want to manage communication issues. If you know that you have a hearing impaired person or a foreign speaker that you're going to see, you want to try to coordinate interpreter services to be available, hopefully via a remote phone line, because it's obvious that they're not going to be coming with you into the home, but to have access to those services if necessary. And obviously addressing any pressure sores, and again, having that caregiver present to help you do positioning to do your assessment. And that's when it may be worthy to bring a tape measure, maybe some culture swabs, and even a cotton tipped applicator to measure any depth of wounds. And then if the family really needs help coordinating services, either connecting them to home health services, which your home visit will suffice as the provider's recording of the interaction to allow Medicare coverage for those home health needs. And so whether you use a home health agency who usually has a social worker available versus your own office coordinator, such as your social worker, or Michigan Medicine uses care navigators, that's what the title of that particular role is called. It's an RN in that role, and they touch base with the patients very frequently, sometimes weekly, to make sure that they're carrying through on the recommended resources that you've given the patient to try to improve their situation. So when you go back, usually I space my visits about anywhere from maybe a month to 3 months, depending on the acuity of the findings found during an initial visit. And so when you go back in, you want to review the previously identified concerns. You want to follow up on those referrals that you made to the community for needed services and make sure that they're happening. And obviously you want to continue to identify any urgent issues that need help. And so, as I mentioned, like we have that care navigator, but we also sometimes have other nurses who get more involved in the management of comorbid conditions and maybe touch base with the patients more frequently. And obviously you want to document your discussions pertaining to anticipation of future needs, especially if you're recognizing that there may be end stage illness kind of getting there. And then of course, referring to hospice when that is an appropriate time to do so. But it's always important to explore patient and caregiver goals, even just short-term ones. So really always asking the patient when you arrive, what are your goals for today's visit? What are the things that you want to talk about? And that way it's not your agenda, it's a shared agenda. So documentation. I was going to share a little bit about what I do for documentation purposes. And there are certain questionnaires that have come in very handy to help you document the important things of why a patient is homebound. And the first one is something called the physical self-maintenance scale. One of my colleagues here at Michigan has built a smart set that includes these assessments, and I just make it into my own template for home visits. And this is one of the common assessments that I do. And this is more about the ability to toilet themselves, all of your ADLs basically. And it has numbering system. And obviously the lower the number, the less able the patient is to care for themselves. And then moving forward to independent activities of daily living. The Lawton Instrumental Activities of Daily Living scale is what I use for that. And that assesses a person's ability to perform more complex tasks like using a telephone, doing their laundry, handling their finances. And it measures 8 different domains of IADLs. And in using these scales over time, you can start to see whether there's early warning signs of functional decline. And that can signal need for further assessment. And then for those who suffer dementia, we use the Reisberg FAST score because this is a specific assessment for those with dementia. So this is not something that you'd use on a child or if it's not been validated in that population. But this is something that I use quite frequently because most of my homebound patients are elderly and a lot of them have dementia. So as you can see with the escalating numbers, that kind of points to a further progression of the dementia. And it's an essential aspect of your assessment of elderly individuals with chronic illness. And it does kind of assess their functional capacity. And it's really readily ascertainable during a home visit. So this is the kind of thing that you don't have to like go through, but in your observations, when you get home and you go and do your note for this visit, you can say, okay, this is the level that I am now seeing, like they're having urinary continence. So that would be a 6D. If they are now limited in their talking abilities, that can be 7A. And as you can see, their loss of ability progresses to the point where they can't even hold up their head. And that would be more end stage, characteristic of end stage Alzheimer's. So it's a very strong diagnostic and differential diagnostic aid that I think would be helpful and beneficial for you to use if you decide to do a home visit. So here's a little bit detail about billing codes. And this was just changed actually effective January 1st. And basically what's happened is CMS has combined all services in facilities where only minimal healthcare is provided. So that can be in your private residence, it can be in temporary lodging, such as a shelter or a hotel. And that's, again, combined with services that are done in facilities which have minimal healthcare provided. So independent or assisted living communities, basically, you can use the same codes for all of those situations. And of course, they have new patient codes and they have established patient codes. And they divide it by amount of time spent, which is usually how I bill. And sometimes visits go over 60 minutes, but I'd say on average, it may last about an hour. And then in the teaching realm here at an academic institution, I use something called the GC modifier, which is if you have a resident physician along with you for the ride, that is something that you can also include in the billing. So where do you fit such a visit into your busy schedule and how do you afford to do it? So in my academic practice, I am 80% full-time. So I'm not even a full-time clinician. I don't think I have it in me to be a full-time clinician. I used to be, but that was when I was younger. In my department, my Department of Family Medicine here at Michigan Medicine has been very supportive, and they have been able to subsidize any lost revenue from taking that time of seeing, the hamster wheel of patient after patient after patient to allow me this half day away to be able to see these homebound individuals. And part of that is my teaching duties where I have a resident or a student with me. And as I mentioned, I see on average 2 to 3 patients in a half day, but depending on where I go, I also go to an assisted living out in Chelsea, Michigan, where I have practiced for my whole career. And I've lost patients over the years because they end up dying off, but they're coordinated in a geographic location. So I'm able to do more visits on a day where I go to that assisted living because I'm seeing all of my patients, or at least the majority of them. And so I might knock out 5 visits, 6 visits in that half day. But if I'm traveling to different locations, then you can't really fit in more than 3 patients in a half a day. And I have helpers in my clinic who help to coordinate these visits, and she's aware to make sure that they're geographically more together than distant, which helps. And so obviously identifying a support staff individual who can help you in scheduling is absolutely necessary. So, and as I mentioned, I have learners along for the ride. It's educational, and honestly, every student and every resident that has ever joined me on these excursions is always like, oh my gosh, that was so much fun. I can't wait to do it again. So for medical students, they get to experience the doctor-patient relationship in the most intimate way. You don't feel as pressed for time when you're in their home, and you realize that you are crossing the threshold of their personal space. And it's just a neat dynamic to have and share with a medical student. And I feel like it can actually help medical students to see that primary care can be sexy in some way. Because I know I'm trying to win more students to come into primary care. And so you want to address with them the factors that influence health. So getting the medical student to discuss things like medication adherence and what are the barriers there, and also allow them to kind of screen for social determinants of health. Let them help you do that work. And the other important thing that I think both residents and medical students get to see is the transition of care between home, maybe after they've had a hospitalization or a subacute rehab stay. Those transitions are very important times in the life of a patient, and making sure that it's a safe transition. And then for residents, whether they're family medicine residents, internal medicine residents, any of the primary care specialties, again, getting them to address medication adherence, decreasing barriers to proper use of their medications, maybe assessing for polypharmacy, doing a literature review to try to improve the safety of their medications, and assessing for drug interactions, referring to appropriate interdisciplinary team interventions, like kind of teaching the residents that you have other home health opportunities, and if you feel that the patient would benefit from those, helping teach the residents to access those interdisciplinary interventions for the sake of the patient's health and well-being. And then obviously addressing any safety concerns, and again, recognizing the stress and burden for the caregivers. And so, there's a lot of challenges in offering home visits, and I by no means think that this is just an easy thing to get up and running. It's not. I certainly had to kind of go to bat for myself and say, this is something that I really wanted to do, because I had already collected a collection of patients that I had followed for many years, but I would do their home visits outside of my regular clinic time. And I realized that that's just not sustainable. So I was very grateful to the department in allowing me to carve out this half day out of my clinic time to do these kinds of visits. So hopefully you work for an institution that is equally willing. And for those of you who run your own practices, you're in charge, so carve out some time to do those home visits. And as I mentioned, like the scheduling process, you want to identify somebody in your clinic who can help you manage those issues. And as I mentioned, I usually see them about every 2 to 3 months. And I might do closer follow-ups, let's say for post-hospitalization visit. I'll try to find a place to do urgent visits. Even though I can't always accommodate an urgent visit, I do my best. And I might have to juggle around certain follow-up visits and maybe space some more farther apart, and then others can be closer together. And I'm only sharing this because I am actually frustrated this year. And I have some individuals in the billing area doing a little bit of background investigating why my reimbursement with the code changes have dwindled so significantly. So as you can see, for fiscal year 22, I did 60 home visits. And for that year, I made just under $20,000. Well, for fiscal year 23, which starts July of 22, I've already done 53 visits. And the unfortunate reimbursement has dwindled by a significant percentage. And so this is going to make it less sustainable. And this is not how I wanted to end the talk, but I just wanted to let you know that I am looking into what is going on here. And if there were billing that was miscoded, we will try to rectify that and hopefully be able to improve the reimbursement, because obviously this is not going to be sustainable if the reimbursement has gone way down. And, other challenges include the time suck. It certainly takes time to get from one abode to another. And that's why I mentioned coordinating your visits by location. And obviously being prepared for exposure to noxious environments. I will give you an example. Just this week, we went to a very lovely lady who lives here in Dexter who cannot get out of her home. But unfortunately, she suffers significant urinary incontinence. And I think the urine is actually soaked into the chair where she sits most of the time. So, yes, we were masked, but maybe putting a little bit of Vicks Vapor Rub under the nose before you put on your mask to kind of disguise the odor and allow you to just carry on with your visit. But obviously, addressing those things and making sure that you address safety issues as well. And lastly, this is the last thing I'm going to say, and then we'll get to questions. So not sure how much time I have left, but I will give you one example of a patient who I cared for in years past, who had, he was wheelchair bound, and he suffered sarcoidosis, advanced sarcoidosis. It was affecting his heart. And he also had a very large need for pain control. But he lived in a home which he could not easily leave without the help of a stretcher, basically. And he did not have the monies. And he wasn't trusting of a lot of people. Now, he used to come here with his roommate. His roommate would get him out of the house. But as his condition progressed, he was not able to get out of the home. So I offered to start doing home visits for him. Well, when I first entered his home, I thought it was abandoned. I mean, it looked like it should be condemned. And, obviously I was very worried about his safety, but he promised me that he lived there his whole adult life, and that they made do. But when I walked in, it was kind of a hoarding situation. There were unclean environments. There were mouse feces scattered about. There, was obviously issues with getting him to the bathroom. So they were using a commode. He was just doing bed baths, basically. But I look back at that experience, and I wonder if some of my colleagues would have ever felt comfortable in that situation. But I knew him, and I knew I was safe. So I continued to provide him those home visits until, unfortunately, he ended up dying in the hospital of septic shock because his conditions just got that bad. But I welcome you to unmute and share any specific scenarios that you wanted to ask me about. So I will stop sharing my screen now so that I can see everybody else's faces. And feel free to unmute, or if we're running out of time, I certainly can go to the chat and answer any questions there. So thank you for listening.
Thank you, Dr. LaMore. So if anybody has questions, feel free to enter them in the chat, or if you want to just ask the question directly, feel free to do so. While we're waiting for that, I do have a couple of questions just to kind of start things off. So how do you determine whether to do a home visit or to arrange Medicab or like some like a covered transportation? I know it depends on the condition. So how do you determine that, whether you would have the care navigator or social worker to facilitate that to get to the clinic versus saying, you know what, I prefer to do a home visit?
So it usually is the conversation between me and the patient. And so, for example, if I had a patient who was able to previously come to see me in clinic, and they now have difficulties with leaving their home, whether it be a physical condition that makes it difficult for them to get down the stairs of their home. I will often also say, well, this is something that I do. Would you be interested? And oftentimes they're kind of taken aback, like, oh my God, you do home visits? What is that? I thought that was a dying breed. I didn't even know that that was an opportunity to have such services anymore. So they're always taken aback. And usually they say, well, let me think about it. I'll talk to my husband or caregiver, and we'll see if that is something that they wish to do. And so I haven't necessarily, I have made referrals, let's say, to the PACE program here in Washtenaw County. If there are significant barriers to the caregiver's ability to provide care, or if I'm worried about the safety of even the caregiver and providing that care, then I may say, well, maybe we need to brainstorm about other options to provide care for the individual, where because the caregiver's ability to provide that care is not safe anymore. And so that's when I will consider referrals to other options like the PACE program. Every individual situation is unique, and I don't have criteria, so to speak. So I always say, well, I'm always willing to come out and start with a home visit, and then we can kind of decide from there what other services would best benefit the patient. So even if it's just a transient visit or two to kind of get the services going that would be best for the patient, then I'd be very willing to hand them off to the next level of care that person actually needs.
Thank
So
you so much.
I think there's a question in the chat.
Yeah, there's in the chat. There's one question.
Sure. Question and answer from Gaza in the QA. Okay, so how do I see what that says? Oh, let me go. I'm not able to see.
Okay, I can read it for you.
Okay.
So Dr. Thomas, a great talk for billing. Do you use only the time spent face-to-face?
I would say most of the time I do go by time spent, but sometimes I use complexity too. It just depends on the comorbid status and how many different conditions we're addressing at that particular visit. But it's certainly easier to just say, well, I spent this much time, and I just document that in the note, and that enables you to build the appropriate billing code. I see another question popped in there.
Yeah, so Dr. Rue said it seems like the chat is disabled. So yeah, sorry, I go to the question and answer part.
Okay.
Do you document? Is it during the visit or after the visit?
So it depends. So normally if I'm going into a home, I'm not going to ask them for their Wi-Fi password and be on my computer while I'm talking. So typically what I do ahead of time, I may print their problem list and their medication list, and then I'll take notes, written notes while I'm speaking, so I don't forget certain things. And it's just my way. I chart after the visit. So that's, when I get home, I will finish up the note. And I actually have my resident physicians, usually I make them in charge of doing one of the visit notes. So if they're with me for a couple of visits, I will have them do one of those visits. So that certainly offloads me somewhat. But I do not typically chart in the patient visit. I typically chart afterward. Although I will say, when I go to my assisted living, I have their Wi-Fi. And so I will get on the computer and I may type the HPI while I'm in with them, and then finish up the rest of the note at the end of the day. Good questions.
All right. While we're waiting for other questions, In terms of people with disabilities, especially communication disabilities, what are some of the strategies that you incorporate? I know you mentioned in your talk having a ranging interpreter if needed. But are there other strategies that you use when you're out doing the home visits?
So for the comfort of the patient, if they would rather have a family member who, if they wish to be the interpreter, I know like that's kind of frowned upon, but for comfort levels, if it'd be strange to have a third party on a phone call while we're talking, then certainly I will invite that family member who is fluent in both languages to be able to share and be that interpreter. But I would say I don't encounter language barriers very often because maybe just the population that I have out here in Dexter, I have very few non-English speaking patients, or at least English as their first language is pretty typical. And even if English is their second language, they usually have a pretty good command of the English language that I don't have to get interpreter services involved. So that's been my experience.
In terms of safety issues, so obviously going into some of these environments, and I can recall one experience not too long ago in which it really kind of forced me to consider getting a court-appointed guardian, and also possibly getting them placed, and it was unfortunately involuntary placement requests. So just curious if you have had experiences like that. How do you navigate that?
So I will give you as quick of a story as I can, but I have an adult patient with cerebral palsy whose mother is also my patient. And the mother has end-stage COPD and she's oxygen dependent now. Well, as her disease process worsened, it became very apparent that she could no longer care for her daughter. And for the safety of the daughter, I explained to Patty that, I think it's time to consider surrogate care for your daughter. And we had previously talked about that because we knew the time was coming. We just didn't know when. And so I was involved. I had to actually be a witness at the court. And it was all over Zoom because it was during the beginning of the pandemic, actually. And so guardianship was transferred from mom to an auntie who now cares for her full time in the aunt's home. And now I do home visits to both the mother and to the daughter. So, because obviously the mother is homebound because of her oxygen use. She does not have access to portable oxygen. She doesn't drive. So that's another homebound patient. That's another example of a homebound patient. Of course, her daughter qualifies because she's wheelchair bound. She's cerebral palsy, and so yeah. If those kind of situations creep up, I certainly will get social work involved, and then we will take the proper steps to ensure the safety of the patient. I haven't had any other instances where I had to get involuntary guardianship from the courts. So in that example that I shared earlier about the filthy living conditions, it was difficult, but he was in his right mind. So I had to just kind of accept that this is how he's always lived, and that I was just going to continue to provide the care that he needed, despite my cringing when I walked in the door, because overall, his roommate was providing him a safe environment in which to exist, and he did take good care of him. So, but those situations do creep up and they are difficult, but that's certainly when it's time to call in the help of your social worker. And then, obviously if it's endangerment, then certainly stepping up to calling CPS or APS and getting them involved in the care as well. And I've had to do that. I really haven't. It's not the most fun thing to do, but when you sell it as this is for your safety, And I would not be doing my job as your doctor if I didn't take the importance of your safety as the top priority. So.
Thank you so much. We're almost at the end of our webinar time period. So I want to thank everybody for joining. And last but not least, thank you, Dr. LaMore, for being willing to present to us. And also
Thanks for having me.
say thank you to Maria for the captioning services today. Dr. LaMore, would you be willing to share some of those resources on some of those you were talking about questionnaires, which I think would be really invaluable for some of our attendees.
Absolutely.
We can certainly put it on the MDisability website as potential resources for people to tap into.
Sure. I think that my references, I didn't get to my reference slide, but I could just actually forward you my slides if you want. I mean, that would be no big deal. Yeah, that'd be fine.
Thank you so much. Thank you, Bettina, and thank you, Dawn, for your help with this and setting it up. Any other last minute items before we close?
Thanks for the invite, Mike.
Okay, I think we're all set. Thank you again for attending. Hope everyone has a great afternoon. Bye-bye.
Bye, everybody.